Well, let's go ahead and look at this medical patient assessment. Before we get too deep into it, I need to back up a little bit and start sort of at the front on these. When you look at medical and trauma assessment, trauma, obviously some sort of accident, car wreck, shooting, stabbing, whatever. Then you have medical, which encompasses everything else. We're focusing on this 6 weeks, just a basic, very, very basic patient assessment. Just enough to get you going. Alright? Assessment is one of the hardest skills that you'll do. I mean, it's difficult because the fact that when you do an assessment, you're asking the patient a question and they're giving you a response, and then from that response, you have to ask another question until you figure out what's wrong. Medicine is quite simple as a whole. When you look at it, it's like a scale. Like if this ruler was a scale, now it's balanced. And on one end, you start stacking signs and symptoms on it. But once you get enough signs and symptoms, that's what it is. So if you were having someone with a heart attack and you had this scale, pressure, pain in the chest, nausea, shortness of breath, boom, heart attack, until proven otherwise. That's as easy as it is. Strep. Think you have strep. This terrible 10 out of 10 sore throat. Drainage. Fever. Act like you ate something dead. Bad breath, dead. Right? Strep breath. You have strep. There's no really big mystery to all this. It's just signs and symptoms you see in clinical medicine anyway. You have the signs and symptoms, and then you have the disease process. And once there's enough signs and symptoms there, that's probably what they have. Okay? So it's not that difficult when we get in there. It's just the questions. When you start asking and answering questions, and to stay systematic with it. Very important to stay systematic with this patient assessment, and these acronyms help you out a little bit. So let me go to this whiteboard and draw this up here for you. Oh, there it is. Okay. So the first thing that you do is you have a general impression of the patient. And PT, little pt, is the abbreviation for patient. So you look at the patient. It's not very good writing. But you look at the patient and you see they're sick, right? You look sick. You probably are sick. You look pale. You're not warm, pink, and dry. Something's wrong. You look like you're in pain. So you have that good first general impression. As you're approaching the patient, you haven't touched the patient yet. You're just sort of walking up to him and getting this impression. The next thing that you have to do is you have to determine the level of responsiveness of the patient. And this is due to eye opening. And this is where you get the AVPU. I know it's sort of a weird sounding thing, but AVPU. AVPU. The A stands for alert, and it's to eye opening. So right now, until you get a little bit more bored, everybody's alert. Everybody has their eyes open. Right? So when I approach you, I look for a good general first impression and see if your eyes are open. If your eyes are not open, then we have to go down this chart here, this acronym, where it says V for verbal. So I go up to you, your eyes are not open, so I go and say, hey, are you okay? And you open your eyes to that verbal stimulus, and then you're responsive to a verbal stimulus. So you would fall under the V. The next one is painful. So and it's a step process, and it's very quick, but the P stands for painful. So you would go up there. Their eyes are not open. You speak to them, they don't respond to you, so you give them a painful stimulus. And this is not like an elbow to the face, or you do one of those wrestling moves where you drop a knee on them or something. Okay. There's a medical way to do this. Everybody take their fist, their hand like this, and sort of crunch it up like you don't give somebody a noogie. Everybody knows what noogies are still? Okay. And turn it around to your sternum with your knuckles down and rub your sternum like you're giving your brother or sister a noogie, not like you don't want the pain. Yeah. That hurts. So you give them what's called a sternal rub. Take the knuckles and you give them a sternal rub. If they respond to that, then they're alert to a painful stimulus. If they don't respond to that pain, then they're unresponsive. Later we will add on unresponsive with a gag reflex or without a gag reflex. Someone that's unresponsive without a gag reflex, they have an uncontrolled airway. So, like from last class, remember ABCs are really important, right? So this unresponsive patient without a gag reflex has an unprotected airway. So we're going to have to do something about that. All right? And we'll learn more about the gag reflex later. Then you get into these other acronyms that we're going to use, where you have sample, OPQRST, and then you would get into your exam and treatment. TX, like that, is the abbreviation for treatment. So that's sort of the system that you would go in, that it would flow to once we started. So we look at it and we say, okay, so what do we have? Are they responsive or unresponsive? Today we will primarily look at the responsive patient, or the person that is awake. Once we get into CPR, we will focus more on the unresponsive patient. So you go in, you do your first good general impression, you go through your ABPU, then your ABCs, you make sure that the airway is open, patent, that they're breathing, and they have a circulation. So if they're responsive, like you guys are, you go up, reach down, grab a radial pulse, and ask them a question, right? And then once they respond to that question, your ABCs are done. They're moving air, they're speaking, so A and B are done, and then they have a radial pulse, so C is done. Once you get in through the ABC, then you enter this sample. Then you start in on your focused history, or the questions. And sample is an acronym that's going to help you keep a systematic approach to this. So the history and present exam is part of the sample. The focused physical exam is where you actually touch the patient. You start doing an exam on the patient, and I have a chart for that you'll go by. And it's called the head-to-toe exam. You just start at the head and you work your way down to the feet. You want to look for any life-threatening injuries or any trauma, anything of that nature. Then you start during this whole process, sort of multitask and start getting baseline set of vitals. The baseline set of vital signs are the first ones. It gives you sort of a base on where to go. If you don't get a baseline set of vitals and you start treating the patient, you don't know where you started from. You have no point of origin. You have to have a point of origin when you start treating patients, so you know if your treatment is any good. So let's look at this first acronym, OPQRST. O would be for the onset. Well, let's just use chest pain, for instance, because that's the easiest example to use. So let's say someone comes in your clinic and they're having chest pain. Once you get through the general first impression, the AVPU and the ABCs, you say, well, when did this pain start? Or the onset. You want to know that. Certain diseases, like someone having an acute MI or heart attack, there's a time limit for certain treatment. So you want to see if they fit into this time limit. When did it start? Provocation. What were you doing? What caused the pain? What were you doing when the pain started? Right? Quality. This would mean sharp or dull, aching. Like in cardiac-related chest pain, typically feels like someone's squeezing the patient or sitting on their chest. So that would be the quality of pain. Radiation, does it move anywhere? Like the typical sign of a heart attack is radiating pain. It radiates into the left or both arms, the neck, the jaw, the back. Okay, so you get radiating pain. You get pain that moves from the chest to the other parts. Severity is on a scale 1 to 10. Again, this is a baseline. You have to get a baseline on their pain because patients can't figure out really too well. Let's say you start treating them when you're giving them medication and you say, oh yeah, what was your pain before the medication? They can't really go back and give you an accurate pain scale. So you have to have that baseline severity because it's the baseline, it's the base, the point of origin. Everything reverts back to that. So let's say their pain is say 10 over a 10, and you give them oxygen and it reduces their pain to 8, or let's keep the math simple, reduce their pain to 5, then just by applying oxygen you cut their pain in half, right? So you had that point of origin and you cut their pain in half. So it gives you a sort of a guide to go by. In time, how long has this been going on? Days, weeks, minutes? So the OPQRST is something that will just, one, spark questions, but two, help you stay systematic with it as well. When we get into the assessment, I have a list of questions. I note that over the previous years, and it's no fault to you guys who struggle with the questions, so I typed them out one day and give them to you so you can memorize the questions. It's easier that way.
What were the first 3 questions? For onset, provocation, and policy.
What?
What were the questions that you asked the patient for onset, provocation, and policy?
Oh, onset is when did it start? Provocation, what started it? You know, were you exercising? Were you resting? That sort of deal. Quality, is it sharp or dull? Pressure, stabbing, burning. All these different pain things have a different, would lead you in a different direction. Tearing type of pain in the chest is a sign or a symptom, actually a symptom of a aortic tear. So their answer leads you down different paths. Then the next one is signs and symptoms. Remember, signs is something that you can see. Symptoms is something that the patient has to tell you. Allergies, this would be to medication. Do they have any medication allergies? Because not in the hospital, right? You can't give medications or stick people with needles or any of that stuff. But in class, in our scenarios, you're going to be giving medications to the patient. So I'm going to have a medication laying out there and say, I'm going to give 1 dose of this nitro. And so you give that medication. So you want to make sure that they don't have any allergies to medication. Are they on any medication, prescription medications? Pertinent past medical history. You want to stay pertinent. Part of the assessment is primarily asking closed-ended questions. Do you have any problems with your heart? Have you ever had a heart attack? Do you have emphysema, COPD, diabetes, hypertension? Because at a certain age, you start asking someone, tell me about your medical history. They may start back at like 1899 or something, right? And so, they'll tell you about the ingrown toe that they had in the early 1900s. And you're like, I don't want that. I need what's taking place today. So, pertinent past medical history. the last oral intake. So you want to make sure to see the last time they ate. Always with the diabetic, you want to see if they've eaten today. And then the other kind you want to see is if they're nauseated, they ate breakfast, you might want to think about seeing their eggs again, right? So the always here, because we'll learn most every time we check what's called a D-stick or a dextro stick, we check their blood glucose. It's a very important diagnostic thing. Then we go to events. What led you up to this? What led you to come into the hospital today? What led you to come to the doctor's office today? What events took place to make you get off of your couch and come into the doctor's office, right? Or in my case, what led you to call 911? What were those events? And these all tie together. The events, I was having chest pain. I was cutting my grass, and I started having chest pain and shortness of breath, and I threw up on the way back in. Boom, you're having a heart attack until proven otherwise. Those are the three biggies in someone having a heart attack. You know, so we will work through that assessment and figure out more and do some diagnostic testing to see if they're having a heart attack. So the OPQRST and sample are very good to keep you on sort of a systematic approach. You may not always be able to find this information out to the patient, especially pediatric patients or the real old. Okay, they may not be able to answer you. So sometimes you have to go with family and friends. You just want to make sure that they're the best historian. The family is sometimes not the best historian. Even though the patient may be a little confused, sometimes they're still the best historian of their care. The family may not be around. And that's sort of the same. When you get your chief complaint, your chief complaint is abbreviated C over C, chief complaint, or C over O with the line it's complaining of. So when you get your chief complaint, now you start to sort of focus in on that. They may have this big old nasty ingrown toe, and you look down at their feet, it's like, oh man, that's infected. But they're complaining of chest pain. So when you focus in on their complaint, their chief complaint, and the chief complaint is what the patient tells you. So if we were to document that, we would put that in quotes. So the chief complaint here would be, I'm having chest pain. So you put patients having chest pain, and then after that, complaining of shortness of breath, nausea, vomiting, dizziness, headache, on and on. So that's sort of the way that you would list it out. Very systematic. I still do a systematic approach. I may not fit in all this stuff here, but eventually, all in line, but eventually I get around to all the same questions. All the same questions that you guys are going to ask. It just may not be as organized. So are they having chest pain? Do they have a prescription for nitroglycerin? Nitroglycerin is the primary medication used for chest pain. It's a vasodilator, so it's very good. It increases blood flow to the heart. Are they having trouble breathing, like maybe with an asthmatic? Do they take albuterol? Do they take a prescribed inhaler? Or allergies? Are they allergic to bee stings? And they got stung by a bee? That would be bad, right? So you're going to have to fix that. So you need to get good general information. A lot of times over their medical history will tell you a lot. It's like the person we're talking about that's having chest pain. Have you ever had a heart attack? You're having chest pain now, have you ever had a heart attack? And if they say, yeah, and it feels just like the pain before when I had my heart attack, guess what? They're probably having another heart attack. If you were to come up and kick me in the shin for giving you that test, it's like, oh man, that hurt. And on the 6 weeks test, you came up and kicked me in the shin, I was like, man, that feels the same as when she kicked me, right? See how that works out? It's the same pain, it's the same incident, just at a different time. So, we have another section here that we'll go through when we look at the focused physical exam. This is when you guys start touching each other. You start at the head and you work down to the feet, head to toe exam. So all these cots that are laying around, that's why we have those cots, because you guys will lay on there and your team members will do a physical exam. They'll palpate your head and chest and belly, check for pulses. And they'll do a head to toe exam. There's no way to do it without practicing. And of course, guys will practice with guys, so we'll divide up. I'm not going to have your parents calling me. It's like, why was that boy touching my daughter's belly in class? Can't really defend that one, right? So now, however, when you get into nursing school, you'll be adult, so it'll be a different thing then, okay? But here we'll stick to the same gender doing the head-to-toe exams. It's easier on me. And we have a whole nother thing on that to talk about. So we'll put that aside for right now, the exam. So the baseline set of vital signs, when we look at vital signs, it's much more than just the blood pressure. Actually, blood pressure is a very bad indicator, initial indicator. We always look at rate. As a paramedic, I look at rate, rhythm, and pressure. Rhythm being the cardiac rhythm that they're in. Okay, but with you guys, you would look at rate and pressure until we learn a little bit more about the rhythms. So rate and pressure. So always look at the pulse rate. The pulse rate will tell you an enormous amount of things about the patient. Pulse rate can tell you about if they're in pain, if they're dehydrated, if their volume is low. I mean, a number of things that the pulse rate that we don't learn will tell you. But here, along with the blood pressure, you look for respirations and pulse rate. So the way that we do the pulse is everybody find their radial pulse off to the side of their thumb. It's the easiest one to find because we're talking about a conscious person. Right? And then we want beats per minute. So when you find your radial pulse, that's why everybody needs a Mickey Mouse with the second hand on it when we go to the hospital. I don't care if it's digital or analog, but you need something to be able to keep track of seconds. Alright, so you find the pulse, you look at your watch, and you start counting. Now we want beats per minute, right? So you could count for 60 seconds, but that would take a long time, right? So what we do, we find the pulse and count for 15 seconds and multiply times 4. 30 seconds, if you count that long, multiply by 2. Only in pediatrics, young children, infants and young children, will you count for the whole minute. And we'll learn the different pulse points later. Like on an adult, it would be here, the radial pulse. On a child, you would check a brachial pulse. We'll learn about that during CPR. On an unconscious person, you would check a carotid pulse in the neck. Everybody find their thyroid, and then go off to the side, one side or the other, and then you have your radial, your carotid pulse. You're too far off. You have this muscle right here, right? And the thyroid, it's in between that muscle. If you're on the muscle, you're too far. You're too lateral. Go more towards the midline. And then everybody find their carotid pulse. So you have the carotid pulse. So you would check that, make a note of it. You guys get really good at multiplying by 4. So 20, let's keep the math easy. So 20, 80, pulse of 80. Normal adult pulse is 60 to 100, so that fits within the norms, right? And then you would count respirations. Now respirations are a little bit more difficult to count. What's the normal adult respiratory rate? 12 to 20. Right? The average fits in between 16 and 18 somewhere. But with the respiratory rate, it's much harder. One, especially if you have clothes on, you can't see the symmetrical rise and fall of the chest, right? When you start looking at someone, and to count the respiratory rate, you can't see the chest rise and fall. And that's what you're counting, right? Inhalation, go 1, 2, right? And you count that for 15 seconds. What I recommend is when you do this, you go up to the patient, have all your wrists. So you go up to the patient, you're checking their pulse, right? And you're doing that. Well, a lot of times, especially in the elderly, you can put your hand on their shoulder, right? They like that. They like the touch feeling. All right. So I'm checking this person's pulse. 15 seconds, I'm like, okay, 80. And then the other 15 seconds, I'm feeling the rise and fall of his back. So I'm feeling his back to feel him taking a breath, right? Because it's very difficult, especially when people have almost impossible when you have a hoodie on, right? You can't look at someone with a hoodie and go count, because then you start staring. Can you imagine doing? Right? The patient right away is, well, what are you staring at? You know, we're trying to count respirations. What I recommend, I know it sounds weird, but what I recommend is that you go home, preferably by yourself, because your parents will think you're weird. Look in the mirror and look at your breathing. Get used to looking at you breathe. You know? And I know it sounds strange, but you're getting used to seeing symmetrical rise and fall of the chest. If you haven't been used to that, like, you know, up till now, it's something to get used to. The same way you go home and find your femoral pulse. That's an important pulse point to find. The femoral pulse is right here. Here's the femoral artery coming down. The femoral pulse is right there. Any questions why we don't practice that in class? So you need to find that, because you may be in a situation where they ask you to see if there's a femoral pulse. So you find the femoral pulse in the patient. And then look to see rise and fall of the chest. The other way is we'd listen with a stethoscope, but typically, if I have a stethoscope out, and I put this on your chest, what's the first thing you're going to do? Yeah, you know, because you're programmed like that. Doctors, take a deep breath. And when you say, no, just breathe normal, that doesn't work, because people go, no, breathe normal. And they keep doing this big breath. So this is a little, you've got to get the patient where they want to make sure that they're breathing normal. So you can listen and count, but it's a little more difficult. You can get what's called an apical pulse on pediatrics, where you can listen. You can put the stethoscope just right off to the left of the sternum, and because that's where the left ventricle is, and count the pulse. I recommend an apical pulse on anything that's really fast. If you have a really rapid heart rate, then you would check an apical pulse. That way you can hear it and count it. Do not, if someone asks you to go get a set of vital signs, do not make it up. If you can't get a blood pressure or the pulse rate or something, just go back and tell them you can't get it. Don't make it up. That's very bad. Now, like on the blood pressure, I know we don't do manual blood pressures. We don't learn manual blood pressures because in case the machine is not accurate or something's wrong with the machine, or it gives you a weird blood pressure, you want to be able to do a manual pressure. 99.9% of the time, you're going to do electronic pressure. You're going to put the blood pressure cuff on, push the button, and it's going to spit you out a number. Up till yesterday, I couldn't tell you the last time I took a manual blood pressure. And I just did it on one of the students. I can't tell you the last time I took a manual blood pressure on a patient. I always just use the electronic blood pressure cuff. But if it gives me a bad number that I don't like, that I don't think I can trust, then I'll take a manual pressure, or have my partner take a manual pressure. So it is important that we learn to do that. Okay, so everybody good on respirations, pulse, beats per minute, respirations per minute, count them for 15 seconds, multiply by 4. We want to check the skin color. We're supposed to be warm, pink, and dry. It's the norm. Not cold and clammy and sweaty. Sweaty, did anybody know the term for sweating? Medical term for sweating? Huh? Starts with a D. Diaphoresis means sweating. Diaphoresis. Spell it phonetically. It's spelled like it sounds. Except the 4 is P-H-O-R. In the hospital, they will want you to do a oral temperature. So you take the thermometer, and everybody knows how to take a temperature, but what they like is the thermometer goes under their tongue, back towards the back molar. It takes only a few seconds. You plug it in, you put it in there, and it spits you out a number. A lot of them have the little thing they rub over their head and check the temperature. All right. You will notice 2 different types of temperature probes in the hospital. One has a blue probe, one has a red probe. Make sure that you're using the blue probe. The red probe is a rectal probe. Fortunately for you guys, we do not do rectal temperatures. Alright, so no, even on babies, especially on babies, on anybody, no rectal temperatures. But when you go get the thermometer, make sure that it doesn't have the red thing in it. It has a plastic cover, but they will make fun of you forever if you put the rectal probe in someone's mouth. You know? But we want to make sure that we get a body temperature. It's a lot of things, fever does. Fever is just a sign of you're fighting some sort of illness, infection. And then pupil size, we'll look at that when we talk about our head to toe. We've already talked about blood pressure, or we haven't figured it out, but we know that we haven't talked about how to do it, but we know that that's part of the vital signs. And then add room air, oxygen saturation. So when the patient comes in, you put the SpO2 probe on them to get a room air oxygen saturation. So those are all part of the vital signs. These are things that you will be doing. Patient checks in, you'll be helping them get them undressed, put the blood pressure cuff on, push the button, maybe hooking them up on the cardiac monitor, putting the SpO2, you may be putting oxygen on them. All right, so there's quite a bit of things there that you're able to do. And then the unresponsive patient, everything is primarily the same. All this is the same, except they would fall under U instead of A in the ABPU. You would still do the ABCs. Your sample and your OPQRST, all that, you will have to get from somebody else, correct? Because the patient is unconscious, unresponsive, so they can't tell you, obviously, right? So you have to get that information from elsewhere. So you will rely on somebody else to be the historian for you. But primarily, even with the head-to-toe exam, everything's the same. Now in your notes for right now, just scratch through this or put a note out to the side for trauma later. This is what we'll cover the last 6 weeks of school, this DCAP BTLS. What this stands for is deformity, contusions, abrasions, punctures, burns, lacerations, something, T. I don't really use it. Tenderness for the T, and swelling, so for the S. So deformity, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. Just sort of an acronym of what to look for on the trauma patient. But we'll pick that up much later date. Any questions on the baseline set of vitals? Okay. Knows what to do there. Like I'm going in the wrong direction. The only thing different, the main thing different is the rapid assessment. Someone unconscious, you would do more of a rapid assessment. A medical patient, you have more time to do that. Everything else is primarily the same.